This video, we're going to look at Chapter 4 in your textbook for the class. Chapter 4 is the basic steps of coding, and I want to cover some items in this chapter with you. Now, I don't record a video for every single chapter in the book. However, if there is a chapter that the class is having a particular hard time with, you can request that I make a video for a chapter. I will either respond back to your answers with answers to your questions, either out on the discussion board or in a course message if there is not enough time for me to get a video up on the website, up in Blackboard in our course space before the deadline for the work. But I will answer any questions on anything in any of the chapters. So the basic steps of coding. You're going to review the health record. That is the absolute key to coding your procedure codes or your diagnosis codes. Now, if you've taken your CPT classes already and your HCPC classes, this would apply to that as well. Your HCPC codes, your CPT codes, your PCS procedural coding codes, and your diagnosis codes, they all have to be supported by the record, by the documentation in the health record. Number 2, you identify the diagnoses and the procedures that need to be coded. Number 3, you will identify the principal diagnosis and the principal procedure. Now, I'd just like to take a second here to explain that what we're looking at with the ICD-10 PCS is inpatient coding. So a lot of this will speak to inpatient coding. But the ICD-10 CM, the diagnosis codes, you would use those as well with your CPT codes, with your HCPC codes, or with your PCS codes. When you are coding, you will always need a diagnosis code or codes, and you will also need procedure codes, whether those procedure codes come from the CPT, the HCPC, or the PCS. CPT has all of your outpatient codes in them. PCS is only your inpatient codes. Now, when you're talking about outpatient, I just want to point out that in that situation, they don't call the principal diagnosis the principal diagnosis. They call it the primary diagnosis. So outpatient, it's called primary diagnosis and primary procedure, and inpatient, they call it principal diagnosis and principal procedure. And what those mean in layman's term is the first listed diagnosis, the first listed procedure. Any of the other secondary diagnoses or secondary procedures would be coded and listed afterwards in the sequence of coding. So you would identify your main term in the alphabetical index. Then you will review the subterms, which are indented underneath the main term, to make sure that you are grabbing the code to the highest specificity. You'll follow any cross-referencing instructions, such as the C also, or the C, or any other cross-referencing instruction it gives you in the index. And then after you have located a code through the index, you will look it up and verify it in the tabular list. You will never code directly from the index to diseases. You will have to always choose your final code from the tabular list. In the tabular list, number 8 refers to any instructional notations in the tabular list. And number 9, assign codes to the highest level of specificity. These two are speaking to any instructional notes that are there, such as the etiology and the manifestation codes, the excludes notes, the number of characters that are required to fully and completely list the diagnosis code. That is all in your tabular section. So you will always choose your final code from your tabular section after you have fully researched all of those scenarios and all of those additional codes and notes that would be there. Number 10, you assign the code to the diagnosis and the procedures, reporting all applicable codes and sequence in accordance with the guidelines. So that gets back to when we were talking about number 3, when I had said there could be multiple diagnoses, multiple procedures. You would list your primary or your principal diagnosis and your primary or your principal procedure as your first listed diagnosis and your first listed procedure. And then your secondary, you would order and code them in addition after. So the review of the health record is where you're going to find your principal diagnosis code. The discharge summary, if available, may be the first document to be reviewed for code selection. The coder reads the summary to understand the highlights of this encounter. The discharge summary is a synopsis of the events included in the patient's hospital stay. Most pertinent information is contained in the discharge summary. Now, the discharge summary will have a lot of pertinent information because it is dictated after they have given the care to the member, run all of the tests, done the surgeries. So they've done all the research, and it is the total outcome that is documented. The physician should list all of the diagnoses and the procedures that were performed during this encounter or this hospital stay. The coder shouldn't solely rely on the discharge summary to capture all the diagnoses and the procedures. You should review the complete record. I'm going to scroll down a little bit here. The chief complaint. So if you have taken your CPT classes, then SOAP, the SOAP note, will sound familiar to you. That is how the doctor or the surgeon, the medical professional, documents their notes. The first thing on it will be the chief complaint, and that is in the patient's own words why they are here today, why they are presenting for care today. The SOAP note, I'll explain that very quickly here. The S in the SOAP note is the subject portion of the note. That is when the doctor and the patient are discussing the review of systems and the history of the present illness. Now, when I say review of systems, I do not mean that in the sense of the exam. That is the review of systems that they're talking about. So if the patient came in complaining of chest pains, the doctor is going to ask a lot of questions around that. How long have they had it? How bad is it? Modifying factors, what have they done to deal with it? When does it come on? Are they exerting themselves? They'll ask them all of these types of questions, and they are reviewing the cardiovascular system when they are asking these questions in the example that I just gave you. If it was asthma, shortness of breath, then it would be the respiratory system. So the review of systems that's happening in the subjective piece is all talk. It's in the objective portion, the O portion of the note. The objective portion is where the exam is actually happening. That's where the doctor is measuring, looking, and seeing things with his own 2 eyes, hearing things with his own 2 ears, and actually giving the physical exam. The A part of the SOAP note, that is the assessment. That's where you will find the definitive diagnosis. Right? That's where you will find your primary diagnosis, your principal diagnosis. Depending on if it's outpatient or inpatient, the term that you would use, you would find all of the diagnoses there, including the secondary diagnoses. Now, if there is no definitive diagnosis, if they suspect that they have a situation or a condition or a disease, and their words like rule out, suspect, possible, that's not definitive. They do not know for sure if the member or the patient has that diagnosis. Then you would code the signs and the symptoms. Now, differential diagnosis would fall into this. This is specifically talking about when a patient presents with symptoms that could be an integral part of many different conditions or diagnosis codes. That would be a differential diagnosis, of which they would have to run additional tests to determine what those signs and symptoms, what is the underlying condition that's causing them. They give you an example here. Patient presents with abdominal pain and the physician suspects that this might represent appendicitis, gastroenteritis, or cholecystitis. So that you would code the abdominal pain as their diagnosis code until the tests have been run and the exams have been done to confirm what it is that they actually have. So here we're talking about locating the main term in the index to diseases. I want to go to the next page because that's where it's going to have some examples for us. We'll also see an example of what a non-essential modifier is, and I will explain that when we get to that example. I will also explain what a subterm is. So here we are. So we're on page 73 of your textbook, and pneumonia is the example that they're given. Now, pneumonia is a default code in this situation. The reason being is all of these other things down here could be happening with this pneumonia. But if your diagnosis that the doctor has written simply states pneumonia, or any one of these non-essential modifiers within pneumonia, so they've documented acute pneumonia, or double pneumonia, or migratory pneumonia, or unresolved pneumonia, any of these non-essential modifiers. When they say non-essential modifiers, they need supplemental words that assist you in choosing the selection of your code. They're not talking about the modifiers that you would see with your CPT codes. If you've already taken your CPT class, you'll know what I'm saying when I say those modifiers. They're talking about modifying words, but they don't actually change the condition or the diagnosis that you have. They're just supplemental words to help you choose the correct diagnosis. So pneumonia is the main term, and in this case it is also the default code. Now, if they have pneumonia with any one of these conditions, let's say they have pneumonia with a lung abscess, now you are coding the J851. You are no longer coding the J18.9. You don't code both of them. The J85.1 would read pneumonia with lung abscess. Take it to a higher specificity with the J85.1. So this is where we're getting into the specificity of the codes. That would apply to any one of these, right? These are all subcategories. Subterms, sorry. These are all subterms. Because it's pointing to aspiration, that's not the only subterm in here. It's just pointing to it as an example. These are all subterms that are indented to the main term. If you're going to code the highest specificity, because you do find a subterm that explains the condition of the diagnosis that you're coding, then it would just be the code in the subterm that you're using. You don't use the diagnosis code for the main term and the subterm. The subterm is the higher specificity. Also, if the main term, pneumonia, and all of its subterms continue on to the next column or the next page, you're going to see that they will show the word continue there so that you'll know you are still in that main term. The next page is showing you non-essential modifiers still exist in all your subterms. You could see them in subterms as well as main terms. This is an example of an eponym. An eponym is when a disease or a procedure has been named after a study or a doctor, because they are the one who did all the research to discover and determine the condition or the procedure. But in this case we are talking about diagnoses, so they would be the condition. All of the integral symptoms that would go along with it, the possible treatments that would go along with it. And so sometimes they will name it after the physician who did all this research and developed the diagnosis, or the study group. In this case, it's called Meckel's diverticulitis or diverticulum. Now you see the main term is diverticulum. If we scroll down a little bit further, you will see that Meckel's is a subterm. And then here are some non-essential modifiers. So Meckel's would be Q43.0, and then you would go to the tabular section and look that up. Now, if you were having some trouble determining what your main term is in a situation like this, a little trick that was taught to me a long time ago when I was a freshman in coding is read it backwards. Often the main term that we're looking for is the first word in our diagnosis. When you read it backwards, now what the first word is. The first word is diverticulum. And that really is the main term. Now throughout the chapters you are going to have these exercises. You could use these exercises as practice questions. I will have the answer keys for them already loaded into the weekly work up on the Blackboard course space. I want to scroll down. The chapter review exercise, those are the questions that will be assigned to you for grading. So if you do any of the practice questions that you already have immediately the answer keys to when you come into the course space, those do not hand in for grading. It is only these chapter review exercises that you will be graded on. Those are the only ones that you should be handing in your assignments for grading. So this is the overview of Chapter 4. If you have any questions, please post them out on the discussion board, or you can course message me, and I wish you happy coding.